Thank you very much, Eleni. First of all, I would like to thank to Professor Irene Lambrundaki, Eleni, Dimitros. A lot of friends are here. There's a growing awareness about the sex differences in human biology and health. In this regard, the sexual dimorphism in the kidney is important. So the physician dealing with the menopause should pay attention to the effect of estrogen deprivation in many organs, including kidney. Therefore, my topic is today managing the menopause in women with chronic kidney disease within the frame of information we have available. So, these are my close. The role of estrogen in the kidney. Here you can see the estrogen receptors in the cytoplasm and the membrane. There are some genomic estrogen receptors and non-genomic estrogen receptors, G-coupled protein in the membrane. And so there are a lot of different kinds of isomers, estrogen receptors, along with the glomerulus and the collecting duct system. So the interesting thing is there is no human data, but there are some evidence from rodent. There is a cyclic change in the kidney similar to menstrual cycle. So along with the aging ovary and deprivation of the estrogen may lead to chronic kidney disease. Mesangial cells result in increase in mesangial cell proliferation, interstitial fibrosis, collagen deposition, podocyte loss, and glomerular hypertrophy. And estrogen indeed maintains the integrity of glomerular and tubular cells, inducing autophagia and through the estrogen receptors, and thus helps the tissue hemostasis and regenerate the kidney tissue. On the other hand, estrogen deficiency has a profound effect on kidney function. I don't want to go in details, but its deficiency may have a deleterious effects on renin-angiotensinogen aldosterone system, and it may decrease the production of erythropoietin. It may reduce the serum calcium levels and increase serum PTH levels, leading to increased bone turnover. And its deficiency have a profound effect on sodium water reabsorption. And what is chronic kidney disease? It's already mentioned, but its prevalence increased by aging, and the risk of CKD appears to be higher for women. And men are more susceptible to developing CKD in early to middle adulthood, whereas the postmenopausal women exhibit a sharp rise in CKD incidence and progression. Androgens exacerbate the renal inflammation and fibrosis, and estrogen exert protective effects, and also the gut microbiota, host metabolic interactions, sex chromosome inactivation, and also unfavorable lifestyle behaviors are important factors for the sex-specific CKD progression. And it was already mentioned by Eleni, so I skip this slide. Why menopause matters in CKD? Chronic kidney disease is associated, because chronic kidney disease is associated with 2.6-fold increased risk of early menopause, and pre-existing cardiovascular disease, hypertension, type 2 diabetes further elevate the risk of early menopause. According to the statement of Kidney Disease Improving Global Outcomes Controversies Conference in 2025, the woman with CKD has a higher risk of osteoporosis and sexual dysfunction. And one another statement was in this conference, the diagnosis of menopause is very difficult in those patients, because sometimes when we treat those patients with proper treatments, the menstruation may recur, may resume. So, on the other hand, menopause itself is associated with reduction in glomerular filtrate rate. This publication appeared in recent years in Maturitas, and premenopausal woman, there's differences between the premenopausal woman and menopausal woman in terms of metabolic syndrome components, but menopause is linked to 50% higher risk of GF, glomerular filtrate rate. This is important, and there are 2 other studies confirm this result. Early menopause and early surgical menopause has an increased risk of CKD. Moreover, each 5-year increment in menopausal age is associated with 11 lower risk of chronic kidney disease. Cardiovascular morbidity and mortality in CKD patients are associated with abnormalities in calcium phosphate balance and related vascular calcification. High phosphate and sclerostin levels in CKD patients contribute to the accelerated mineral deposition in the vessel wall and increased arterial stiffness. Moreover, vitamin K form 2 diminishes the development of hydroxyapatite within the blood vessels. Bone fragility in women with CKD is attributed to a complex combination of primary osteoporosis, drug-induced effects, and CKD-related bone abnormalities. Therefore, we may conclude menopause may occur earlier in those patients, and there are overlapping risk factors between the menopause and the chronic kidney disease. These factors are related with the cardiovascular disease, bone loss, urogenital dysfunction, especially the sexual dysfunction, and the menopause management can directly affect the quality of life. Therefore, the true evaluation of a postmenopausal woman with CKD is necessary. It includes the diet control, physical activity. Of course, as mentioned before, the blood pressure control is essential, and the assessment of severity of climacteric symptoms and the bone loss should be evaluated. And the bone loss can be evaluated according to the National Osteoporosis Guideline or some other societies' guideline. So this is very important for us in the management of this scheme is very important for us in the management of postmenopausal women. This is a CKD, chronic kidney disease classification based on cause. It may be due to the diabetes or hypertension, whatever, glomerular filtrate rate, and albuminuria. If the patient with hot flashes, vasomotor symptoms, is in the low risk, so we may offer these patients to use the preferably the transdermal patch or gel, or it is wise to avoid to use the systemic estrogen treatment if the patient's in high risk in the red boxes, if the patient is in the red boxes. What are the MHD indications for those patients? It's classic vasomotor symptoms and genitourinary syndrome of menopause. A woman with CKD patients experience fever and less severe vasomotor symptoms. However, these vasomotor symptoms can disrupt the sleeping, and the poor sleeping characteristics such as poor perceived sleep quality, shorter sleep duration, low sleep efficiency are associated with double odds ratio for declining renal function in postmenopausal women. Sleeping is important. And moreover, MHD lowers the odds of declining renal function in those patients. And cognitive function, The patient with CKD suffer from the cognitive impairment, and the severity is directly related with the severity of albuminuria. And a Korean nationwide observational cohort study, 700,000, more than 700,000 postmenopausal women with CKD, and they were followed up during the 7 years, and 25% of women showed the cognitive impairment, and MHD was found to be associated with a lower risk for all kinds of dementia for this study. MHD seems to improve the cardiovascular disease in those women, and MHD should ideally be planned around the time of window of opportunity. And data analysis of Women's Health Initiative clearly showed the association of kidney function and with the incidence of heart failure. And here you can see the grading for the classification of the estimated glomerular filtrate rate, and also the heart failure were grouped according to the echocardiographic findings. Heart failure, preserved ejection fraction, reduced ejection fraction, and mid-stage ejection fraction. So by declining glomerular filtrate rate, there's an increased incidence of heart failure. And moreover, the women with current hormone use appear to be attenuated with attenuated the association of chronic kidney disease with incident heart failure when compared to those women with no hormone use or past hormone use. Another study, this is the population-based cohort study from the South Korea, and this study included more than 768,000 menopausal women with chronic kidney disease, and the study aimed to investigate the impact of MHD on cardiovascular disease, renal outcome, and all cause of mortality. Here you can see the woman with MHD has had a decreased risk of myocardial infarction, ischemic stroke, end-stage kidney disease, and all cause of mortality. And the study suggests the potential benefits of MHD in those women. Regarding osteoporosis, we know that raloxifene improves the BMD, lumbar spine, and femoral neck when compared with the placebo in women with CKD. But one should keep in mind the raloxifene has some adverse effect in regard to cardiovascular system, and it may increase the risk of venous thromboembolism and so on. On the other hand, basodoxifene enhances the renal function. For women with osteoporosis or high-risk fracture risk, upon assessment with the FRAX algorithm, and the management involves the classification of CKD stage, and then by collaborating a nephrologist, the metabolic control is essential. Then the lifestyle modifications should be taken by adjusting the daily intake of calcium and vitamin D, and we have to force our patients to do the weight-bearing exercise and cessation of smoking. Smoking is very common in Istanbul, so I stressly focus on this problem really. Beyond the MHD, we may use denosumab, PTH analogs, and romosozumab. And these agents are not retained in the kidneys. This is important, and it was reported the reduced fracture rates in postmenopausal women on these treatments, especially with denosumab or PTH, with a significant risk, with a significant increase in BMD levels, And safety concern in postmenopausal population include the risk of atypic fractures, hypocalcemia, and osteonecrosis of the jaw for denosumab, hypotension for PTH analogs, and cardiovascular events for romosozumab and hypocalcemia as well. So, what are the dose, MHD dose for those patients? The dose are unknown really, but the dose of 17 beta estradiol for those women should be reduced 50 to 70%. Than that described for women with normal kidney function, and there is no specific staging cutoff values. There is no precise information available on dosing for progesterone, and close monitoring is necessary because we may use cyclosporine or tacrolimus in the treatment of CKD patients, and if we give estrogen to these patients, we may cause toxicity. And we should always remember the risk of coronary heart disease, VTA, and stroke. These are known to be higher in women with CKD. So, after in the management of postmenopausal women with CKD, after cessation of smoking and after controlling the blood pressure and lipid and glycemic management, we may offer to those patients who have severe hot flashes, we may offer systemic MHD by giving transdermal patch or gel to alleviate hot flashes, and it is wise to avoid systemic estrogen in patients, in those patients with high risk. So we may offer those patients local vaginal estrogen treatment for vulvovaginal complaints, and also we may consider to use non-hormonal treatments. We may use oxybutynin, clonidine, gabapentin, fezolinetant, venlafaxine, desvenlafaxine, and the other SSRI. But one should keep in mind there is no clear safety threshold for those women, and the close monitoring clinically and by checking the glomerular filtrate rate and the creatinine clearance is necessary, is essential for those patients. So thank you for your attention, and I will refer you to our recent EMAS guideline for the further information. Okay, thank you very much.